Hello everyone, and thank you for watching this presentation. I'd like to talk with you about a Moyamoya disease, a condition that often goes unrecognized until it causes a devastating stroke, but one for which we now have very effective surgical solutions. My goal is simple: to show you what disease is, how we recognize and diagnose it, and how surgery can change these patients' lives. So, what exactly is it? Moyamoya is a rare, progressive disorder of the major arteries that supply the brain. Over time, the internal carotid artery and its branches slowly narrow, blood flow to brain decreases, and the risk of stroke rises, both ischemic and hemorrhagic, as you can see in the CT scan images. The name itself tells the story. Moyamoya is Japanese for puff of smoke. As the main arteries close down, the brain compensates by forming tiny collateral vessels at its base, and on angiography these create a hazy smoke-like appearance, which is where the name comes from. But the problem is that these vessels are weak and cannot fully replace normal circulation. Because it's progressive, it does not stay still. The narrowing worsens over time, so the brain gets less and less oxygen, while those fragile collaterals are under rising pressure and may rupture. The critical point: stroke risks exist at every stage. There is no safe phase, which is exactly why early recognition matters so much. How do these patients present? The symptoms usually mimic a stroke or mini-stroke, a TIA: weakness or numbness on the side, facial droop, difficulty speaking or understanding speech, sudden confusion or poor coordination. In a TIA, these resolve within 24 hours. If they last longer, an actual stroke has occurred. Many patients have repeated TIAs before the diagnosis is made. It is also worth distinguishing two terms. Moyamoya disease is a condition on its own with no identifiable cause. Moyamoya syndrome is the same vascular change appearing alongside other conditions: sickle cell disease, neurofibromatosis type 1, Down syndrome, prior radiation, or certain genetic disorders. The angiogram looks similar, the clinical context is what differs. How do we diagnose it? Very often it's found during the workup for stroke or TIA, and imaging is the key. CT angiography is usually our first study. It gives a clear view of the brain vessels and can show that classic puff of smoke at the skull base, as the arrow points out there. Here is CT angiography in more detail. The arrow marks the narrowing of the major arteries and the abnormal network of collaterals. CTA is widely available, non-invasive, and gives us excellent anatomical detail for planning the next steps. Unfortunately, many patients are diagnosed only after a stroke. On the left, an ischemic stroke, brain that has lost its blood supply. On the right, an hemorrhagic stroke, bleeding from one of those fragile vessels rupturing. Both are devastating, and both are preventable if we catch the disease early. The gold standard remains the cerebral angiogram, or DSA, the most detailed test we have for cerebral blood flow. Using a small catheter and contrast dye, it lets us see the vessels in real time, and the detail is essential for surgical planning. And this really shows the difference. On the left, a normal angiogram, clean, well-organized vessels. On the right, a Moyamoya patient, the narrowing and that dense, chaotic tangle of tiny collaterals. This is the puff of the smoke, and once you have seen it, you'll never forget it. MRI is another important part of the workup. It tells us whether a stroke has already occurred. These bright changes are areas of prior injury and shows how much of the brain is involved and how urgently we must act. CT perfusion goes one step beyond the anatomy. It shows how well blood actually reaches each region of the brain. We can see areas where perfusion is compromised even when the tissue still looks normal. Invaluable for deciding which side is at the greatest risk and which to operate on first. So, bringing the imaging together: CT angiography for anatomy, CT perfusion for blood flow, and the catheter angiography for the most detailed roadmap. Used together, these give us a complete picture before we ever enter the operating room. Now let's turn to treatment. There are two arms, one on the medical side, and I want to be honest about this: there is no cure for Moyamoya. We use aspirin to reduce clot formation and provide supportive care, but medication alone does not stop the disease. Surgically, we have two main options: direct bypass and indirect bypass, most commonly EDAS. So why do we operate? For three reasons. First, to reduce ischemic stroke by restoring the flow. Second, to reduce hemorrhagic stroke by relieving pressure on these fragile vessels. And the third, something we sometimes underappreciate, to improve cognitive function. Once the brain is properly supplied again, many patients actually think more clearly than before. There are two surgical approaches: and the difference matters. In a direct bypass, we take a scalp artery, the superficial temporal artery, and sew it directly to the own artery on the surface of the brain, creating an immediate new pathway for blood. In an indirect bypass, we lay that same artery onto the brain without stitching it. Over 3 to 6 months, the brain grows its own new connections and circulation improves gradually. And this is the result after surgery. On the 3D reconstructions, you can see the scalp artery brought inside the scalp. On the CT, the arrows mark the donor artery, the superficial temporal artery, connecting to the brain artery, the middle cerebral artery. A successful bypass restores blood flow to a region that had been chronically starved. During surgery, we confirm the bypass is working in real time. On the left is the completed connection. On the right, a fluorescent dye called ICG green lights up the vessel and proves the bypass is open and flowing. This confirmation matters. We never want to surprise in the days after the surgery. On the left, an indirect bypass, the artery laid gently onto the brain where it grows new collaterals over the following months. On the right is what I prefer in most adults, a combined bypass. The upper circle is the direct connection for immediate flow. The lower is the indirect part which keeps building new vessels over time. This way we get to the best of the both worlds. Let me show you how this actually looks in the operating room. Before any incision, we use a small Doppler probe to trace the exact path of the scalp artery and mark it on the skin. This artery has two branches, frontal and parietal, and either can serve as our donor. Then comes the delicate part. You can see me carefully cleaning this artery, stripping away the surrounding tissue because it's a few moments we still sew it to the tiny artery on the surface of the brain. These vessels are only a few millimeters across, smaller than a grain of rice, so the whole connection is done under high-powered microscope with stitches finer than the human hair. Once it's complete, we use the Doppler again and then the ICG green dye to confirm fresh blood is now flowing through our new pathway and lighting up the brain. Finally, we add the indirect bypass. We lay a second vessel and its tissue directly onto the brain without stitching, so that over the coming months, the brain grows its own new blood supply. Together, one bypass that works immediately and the one that develops over time, these give the brain the lasting circulation it needs. Now, what happens after the surgery? The operation takes 3 to 5 hours under general anesthesia, and afterward, every patient goes to the ICU because we need careful monitoring of the blood pressure, hydration, and neurological function. The typical hospital stays is 4 to 7 days and full recovery about 2 to 6 weeks. During that time, 3 things matter most. Stay well hydrated, keep blood pressure normal, and continue aspirin. I really emphasize hydration. Dehydration, especially in hot weather, can worsen symptoms. Follow-up is essential. On the first day after surgery, we obtain a CT angiogram or catheter angiogram to confirm the bypass is open. After that, we repeat imaging at about 1 year and then as needed. Because Moyamoya is lifelong, even after a successful bypass, these patients are monitored for lifetime. Finally, let me share what I personally do differently. In every suitable adult, I perform both a direct and 2 indirect bypasses, including IDAS and the frontal burr hole, which adds blood supply to the anterior cerebral territory, an area often undertreated by a standard bypass alone. It is a technique I learned and refined in Nagoya, Japan, one of the world's leading centers for Moyamoya surgery. The guiding principle is simple. For a disease this complex, more complete revascularization is better revascularization. So to summarize, direct bypass gives an immediate increase in blood flow and lowers early stroke risk. Indirect bypass builds new vessels gradually for excellent long-term improvement and stays useful when direct isn't feasible. But the real power is in combining them, immediate and long-term perfusion together, and lowers future stroke risk. In my experience, this combined approach is the optimal strategy for most adult patients. Thank you very much for your attention.